Okay, let's go over snap, crackle, pop, fractures, casts, traction, and complications. So a fracture is any break in the continuity of a bone. It can be caused by trauma, can be pathologic. So this is if there's cancer or osteoporosis, it can cause weakening to the bone. And so they get a pathologic fracture or a stress fracture from just everyday activity. So I had a friend that had a history of cancer. She got up one morning, was walking to the bathroom, felt a crack, and had a complete fracture of her femur. My grandma one time was cooking Thanksgiving dinner, reached over into the stove to get the turkey out, and ended up with a fracture in her back. So those would be some, and that was from osteoporosis, like pathologic fractures. They can be stable, meaning that the bone is not displaced, or they can be unstable, meaning that the bones can shift around, closed or open. Open fractures occur when the bone protrudes through the skin, and they are much, much more prone to infection. Closed fractures, there's no break in the skin. So here's an example of an x-ray. Typically, the signs you're going to see is there will be localized pain. They'll have decrease in range of motion or use of that extremity. They can't bear weight. They'll guard that. And so sometimes with young children, when they get a fracture, that's what we'll sometimes notice is just that extreme guarding or not using a limb that they should. You might see obvious limb rotation, or especially like with hip fractures, you'll notice like a shortening when you compare like right to left, a shortening of that limb. Swelling or bruising are some of the things that you'll see. You might also hear crepitus, which is actually a crackling sound that you can hear in between two bones. So here's some of the types of fractures so that you get just a kind of look at what, how they look. An oblique fracture, a break occurs at an angle across the bone. The comminuted, a break has more than 3 fragments to it. Spirals from a twisting of the bone. And then that compound is right there. It's completely across the bone, and then you'll see it protruding from the skin there. Green stick fractures, it's an incomplete fracture, and there's kind of like a splintering there. So they're incomplete. One side of the bone is broken, and the other side it's flexed, but it's still kind of intact. And then you'll see the transverse and simple. So first, your nursing care is going to be, as always, check our ABCs, just to make sure that, depending on where that fracture is at, that we don't have any life-threatening injuries. Depending on the type of injury, they make sure there's no spinal cord injury involvement or bleeding. And then make sure you know those 5 P's of that CSM check, which are pain, paresthesia or tingling, pulse, pallor, and paralysis. These are things that you're going to hear over and over in ortho care. Splint it as it lies. You are not the doctor. So until we get x-rays and know what type of fracture that we're dealing, if you try to realign that, out there at the site of the injury, you can actually end up causing more nerve damage. You might end up, because of the fracture, causing more bleeding. So splint it as it is until we get to a hospital setting, can get x-rays and know what we're dealing with. Immobilize it by splinting it above and below that joint that we have. So our fracture treatment is going to be closed reduction, and this is when we can do manual realignment of the bones. We can then either keep that realignment by placing a cast, using traction, or external fixators, and we'll talk a little bit more about that, so that the skin remains intact, but we're able to manually move to get bone realignment. Open reduction is when we have to take the patient to surgery under anesthesia, and there's typically an incision to get those bones realigned. Sometimes they'll take them to surgery like with kids for a closed reduction because they may just not be able to tolerate the pain. So just because they go to surgery doesn't mean they're getting an open reduction. I have seen sometimes people have to be taken to surgery under anesthesia. They're able to manually get the bone in realignment and place a cast. But depending, if you have a lot of bone fragments, we're worried that when we do get with a lot of complete fractures, we can get it realigned, but we're afraid it's not going to hold even with a cast in alignment. So sometimes we need to use rods, pins, or other devices to keep those bones realigned. And so we go to surgery and can do what's called an open reduction. There's a surgical incision. We can use pins, other devices to keep the bone in place. And so that's an ORIF, an open reduction. With internal fixations, that means there's hardware internally. Traction, and we're going to go into that here in just a minute, is when we use some type of pulling force with counter traction. So this is an external fixator. And so this, you'll see the hardware outside of the patient. We still have rods and pins that are going from the external to internal to get that bone realignment, and these will stay in place till we get adequate bone healing and growth, and then the external fixator device can be removed. Here's the external fixator to hand. And again, this is high risk for infection, so we need good pin care, good assessment of infection. They'll all need good check of those CSM, those 5 Ps. And then this is an example like when we have internal fixators. So we've got plates and screws put on to hold that bone in realignment, or sometimes, especially with femur, you'll see an intramedullary rod placed where they'll drive a rod down through those bones. And then this would be like in a hip fracture where they'll use rods or screws to again hold that the head of the femur in place. And so there's all types of hardware that can be used in, realigning the bones. And it's amazing the amount of hardware sometimes. So here's like a pelvic fracture with some hardware in place. But some of these, especially when you get, like crush injuries where the bone's in multiple fragments, you'll see lots of different types of hardware used. So with traction, those external fixators are a type of skeletal traction. So you can use pins, screws, tongs, and you can actually apply. The external fixators don't have weights, but you can actually have external weights applied with some skeletal traction, or you can have skin traction, and that's like bucks. I put a video into the course on how to apply bucks traction. And so this is where we'll use a device, and then this cloth device have these weights hanging off the end of the bed, and then that has that counter traction to hold that extremity out to keep that bone in alignment. And so this is kind of just a picture showing what that looks like. These weights need to be kept free hanging. So they don't need to be set on the floor, on the bed. It's very important that you've always got the weights free hanging. Anytime, regardless of the type of fraction, you want to do those neurovascular checks. You want to make sure that the equipment is properly in place every 8 hours, every shift. Keep those weights free hanging. Don't remove the traction or those bones can get out of alignment. If it's skeletal, we need to do pin care and assess for infection. These patients in traction tend to feel isolated because they have that prolonged bed rest. And so make sure and remember while they're in traction, you know, they're going to be high risk of skin issues related to that immobility. And then we can also have the use, and more commonly you're going to see the use of just casts, bandages, and splints used to hold that bone alignment. So used to, we always used those white plaster of Paris cast were frequently used, and sometimes we'll still see those. They do take longer to dry, but sometimes with big cast or weight-bearing areas, you will still see plaster of Paris. But typically for like arm fractures, we'll see the use of fiberglass casts. They are lighter. They get hard quick and they dry within 2 hours. There are some waterproof casts, or if we don't have waterproof casts, we've got kids and it's summer and they want to swim, there are some sleeves that can go over casts so that they can swim. But we do want to make sure that, like with our casts, if they're not waterproof, most of them, like, they're wrapped with cotton inside. So if they submerge that cast, that is going to become a wet, moist mess inside that cast. And so we want to make sure people know that they shouldn't just submerge that cast unless they have something to make that cast waterproof. After we've got that cast applied, they need to keep that limb elevated, because remember, they've had a fracture, they've had an injury. And so, you know, it's common to have swelling after a fracture. So if we elevate it, we can minimize some of that swelling. We can use ice to try to reduce the swelling. And we want to make sure in that first 24 to 48 hours that we are checking CMS. We want to always make sure that the cast is dry, that it's not, if we do have swelling, that it doesn't get too tight. And so our CMS checks will tell us that. If we see that we have distal to the fracture, sluggish capillary refill, pale nails, they're cool, that's a sign that cast may have gotten too tight. And so that's why we want to do those frequent CMS checks. We also need to be aware of later on down the road, you know, a week or two, and that swelling subsides, cast can get too loose. So you always want to check that tightness, make sure that it's secure to where it holds those bones in alignment, but it's not too tight, and that it doesn't become too loose. It's common to have some odor with casts, like if they're usually going to stay on 6 to 8 weeks. So just by sweating and dead skin scales, we see some odor. But if they had an injury and had some type of an abrasion, we want to make sure we don't get any infection under that cast. So we're looking for, sometimes you can actually feel hot spots in a cast. If you see any type of drainage, if they have a sudden increase of pain, we want to be kind of thinking like, could they have an infection? Or if they have a real malodorous, more than like what's typical with a long-term task, we want to look for any types of infection. So this aqua kind of color is where the cast is. And you'll see that they'll usually go, you know, below the joint below, the cast terminates below that distal joint. And then it's also going to go above the proximal or the joint above. and that cast will go the entire. So it's not just right there to where that fracture is at. We have to really keep that area immobilized by immobilizing the joints above and below. This is just a example of a splint or an immobilizer. This device can be taken off and on. And then there are some complications of fractures. So hemorrhage, infection, some new ones you may not have heard of, but they're dangerous, are compartment syndrome and fat embolism. I feel like hemorrhage, infection, and thromboembolic or DVTs, you guys have had plenty of kind of discussion of, but we'll talk a little bit about the other two here, because they're kind of new. And then non-union is something. That's when the bones do not stay in alignment. And, you know, typically after we apply a cast, they're going to come back in a week, have another x-ray to make sure that that's in union. Sometimes I've seen if they come back and the cast isn't holding it, that's when maybe they have to go to surgery and do some other type of, you know, immobilization of the fracture. So, fat embolism. So the risk for the development of fat embolism, this is a syndrome in which a fat globule migrates into the bloodstream. It gets combined with platelets and it forms an emboli. It's at greatest risk in the first 36 hours after a fracture. And we typically see this in our clients that present, they've got multiple fractures. So they've had a big trauma, or they've got a fracture of the long bone, such as, you know, a femur fracture, or a fracture of the pelvis. The initial symptom of a fat embolism is confusion. That's related to hypoxia. So we'll typically check blood gases and look at the PO2. We want to assess for respiratory distress, restlessness, irritability, fever. You might even see some petechiae. If an embolus is suspected, notify the physician stat. We want to get blood gases, administer oxygen. They'll probably need endotracheal intubation. This is an emergency. So we want to make sure that we do, you know, those neurovascular assessments distal to the injury, and always look for symptoms of, you know, fat embolism, especially in those patients that have had, you know, a big trauma or a fracture of a long bone. Compartment syndrome is when we kind of get that severe edema and swelling, and then it causes a decrease in perfusion to the surrounding tissue. So this just goes in. You'll see it when we've got that increase in pressure, when that pressure in that extremity compartment increases and then causes that decrease in perfusion. So it's very serious. If we don't catch it, they can have neurologic or massive further injury to that. They could even end up, you know, with an amputation if we end up with, you know, a severe ischemic injury. And this just kind of shows what we're talking about when we say like compartments. So these are like those internal compartments where you've got, you know, the fascia, muscles, our bones here. Here's the tibia, fibula. So because of that edema, we end up getting, you know, changes in pressure in those compartments. So this again is back to those 6 P's that we're always assessing. And so you'll see with compartment syndrome, they start complaining of numbness and tingling. They have pain that's not relieved by our, you know, use of cold or our pain meds. They've got those pill extremities. They can't move them, lack of pulse, all of these. And then again, they've got that pressure from that increase and pressure. And so with that, we need to remove the pressure. So this is actually an incision that is placed into that compartment to try to relieve the pressure. It's called a fasciotomy. And then this is actually, after there's been like an unsuccessful fasciotomy. And so again, you can tell this is a major trauma event. We've got lots of hardware placed here. And then, because of all of the successive, probably fractures, hardware placed, we end up and had severe swelling that resulted in compartment syndrome. And so this is typically going to be related with poor healing. And then venous thrombus prevention. Prevention's key. We've had a lot, you've probably already talked through in fundamentals, that we want to prevent blood clots, our SCDs, even just having patients do foot pumps with their feet, if they can't move an extremity. So dorsiflex, plantar flex, range of motion of unaffected extremities. And when we can get them moving, get them up and moving. And then you will see prophylactic anticoagulants. Enoxaparin, Lovenox is commonly used nowadays. Used to be used heparin, but it's usually now more that low molecular weight, such as Lovenox. And we already talked about fat embolism. Here's our acute respiratory distress. This just kind of summarizes our discussion that we already had. And again, it is an emergency, just like with any embolism. So make sure after fracture, do those neurovascular checks, manage pain, watch for good skin care. These are patients that will, after we get them stabilized, have some type of physical therapy. And then make sure we've got good nutrition, including enough protein, calcium, and daily multivitamins.